So today we're going to talk about bipolar, and we will be focusing mostly on the manic phase of bipolar, as we've already discussed the nursing diagnoses and nursing interventions for depression, which are the same in major depression as they are in bipolar. So by the end of this lecture, or at least by the end of the week, you should have an awareness of the causes, prevalence and course of bipolar, understand the symptoms, understand the diagnostic criteria according to the DSM, be able to conduct a mental state exam for someone with bipolar, be able to list at least 5 nursing diagnoses and 5 interventions for each of those diagnoses, have an understanding of the non-pharmacological treatments and the pharmacological treatments for bipolar. So it is actually quite an uncommon disorder. It's only around 1% of the population will have bipolar. You may see people talking about kind of having manic depression or having ups and downs, but again, this is one of those situations where the DSM criteria are quite strict with the exact symptoms that someone must present with and for how long. It's most commonly onset in early adolescence, and there is some evidence to suggest that it's more common in females, but it depends on what literature you read. There is a strong genetic link to bipolar as well. And the stronger the family history of bipolar, the more likely you are to have increased episodes of mania across a lifetime. Again, as with most mental illnesses, there's a number of different causes. There's the genetic factors, which actually is highest rates of genetic factors affecting mental illness in bipolar. So it's actually around 20% of people with first degree relatives with bipolar are likely to have bipolar themselves. Again, it's in combination of psychosocial factors and neurochemical factors. Stressful events that can lead to hormonal and neurophysiological system disruptions. So again, traumatic events, stressful life events, anything that can lead to a hormone change can be a trigger for bipolar, usually if you have a genetic history. Neurochemical factors, increase in the presence of serotonin, noradrenaline and dopamine. Remember, we were looking last week at the effects of neurotransmitters in depression. Again, similar neurotransmitters, but we're also looking at noradrenaline and dopamine this week. So there are a number of different aspects of bipolar, or different kind of subtypes, I guess, of bipolar. In bipolar, you may have both depressive episodes and manic episodes, and it's cyclic in nature. This isn't a situation where it's one day someone's high, one day someone's low. It isn't that fast cycling. Usually you might see people with 1 week at a time of either highs or lows, and then they will go from high to normal, and then after some time they might be low, or they might not become low. Mania is the term we use to refer to the elevated aspect of bipolar, where there's a persistently elevated mood, which may be presenting as elation or irritability. So someone who has a high mood, who is manic, may present with irritability or agitation, increased physical activity, and that doesn't necessarily mean things like going to the gym. It just might mean that they're increasingly active throughout the day. And it may be indicated by poor judgment, or can lead to poor judgment. And poor judgment is one of the biggest problems with bipolar. It can lead to lots of different kinds of risk-taking behaviours that aren't usual for that person. It might be driving recklessly, or sexual disinhibition, acting in an agitated or violent manner. And these aren't one-off outbursts. This would be consistent presentations that fit that kind of criteria. There are 2 different types of bipolar. Bipolar 1, which includes 1 or more manic or mixed episodes, and it may have a depressive episode, but that's not required for diagnoses. And bipolar 2, which is characterized by an episode of hypomania and a depressive episode. So hypomania will have similar symptoms to what mania does, but they'll be to a lesser degree, and they won't impact so much on functioning. Whereas in bipolar 1, you'll see manic or mixed episodes. So it might be a pattern of manic episodes or a pattern of manic and depressive episodes, but you can be diagnosed with bipolar 1 without having had any depressive episodes. We'll probably focus more on bipolar 1 because we are looking at the more extreme ends of behaviours and symptoms that you'd see in mania rather than hypomania. But you will need to have an understanding of both and recognise that hypomania can be quite similar to the symptoms that you'd see in mania. Again, you'll see the DSM criteria written out in full in the additional resources for this week. It does require for bipolar 1 for a person to have had a distinct period of abnormally and persistently elevated, expansive or irritable mood lasting at least 1 week. And during the period of mood disturbance, there needs to have been 3 or more of the following symptoms. So inflated self-esteem or grandiosity, and you'll hear this word grandiosity quite a bit this week, and you might hear it in relation to a general feeling of grandiosity, or it might be in relation to a grandiose delusion. Grandiosity generally means a heightened sense of self, that someone's more important than what they are, and I'll tell you some more examples of that when we get to grandiose delusions. They might present with a decreased need for sleep, more talkative than usual. Generally their speech will be quite rapid. They'll have what's termed flight of ideas, so racing from one idea to another, and they might say to you, my thoughts are going 1,000 miles an hour. They might tell you they've got racing thoughts. Usually very easily distracted, and excessive involvement in pleasurable activities. So that kind of filter of responsibility almost is gone. Rather than I must go to work, I must do this, or do my homework, it will be an increased desire to purely be involved in pleasurable activities. The mood disturbance must lead to impairment in social or occupational functioning and not be due to substance abuse or other medical conditions. And again, we can see, as with any mood disorders, we can see similar presentations where there are thyroid problems or other hormonal conditions. And a manic state's also quite similar to the way someone presents when they're high on ice or any other stimulant. So of course the mental state exam for someone with bipolar. Someone with bipolar may hear voices, they may have auditory hallucinations. Generally the auditory hallucinations for someone who is manic might be command in nature, they could be derogatory, commentatory, persecutory or religious in nature. Again, the person's often, they might have grandiose delusions, so if they do have those delusions, their auditory hallucinations will fit in with what they're thinking or what their mood is. So if they're elated, they might hear the voice of God talking to them, but if they're quite irritable or low, then they might be experiencing persecutory hallucinations. Visual hallucinations are also possible in bipolar, but they are less common. Someone's affect is likely to be reactive, it's going to be congruent to their mood, remembering that this is the objective expression of emotion. Usually they will look quite happy or quite elated. The mood is obviously what the person describes their mood to be. They may describe it as being amazing, the best mood they've ever had. They might say that they feel quite high. They might say that they feel irritable. Speech is usually pressured, very rapid speech. They'll be talking very quickly like this and you won't understand anything that they're saying. It can be very difficult in an interview, and we'll see examples of that in the simulation activities this week. Usually normal tone, but can go quite high, abnormally high in tone. You might see things, and these are some new terms for you. You might see things called loosening of associations, where the ideas in the sentences or the conversation aren't connected, so they'll go from one topic and start talking about something completely different. They can be tangential in their speech, so wandering from one topic to another but never going back to the original point. Circumstantial is where they're wandering from topic to topic but they do get back to the original point, and you'll see this when in interviews with people. Have a look out for these symptoms in the interview that I put in for you for the online activity this week. You'll see examples of somebody being asked a question in the interview, and then they'll go off wandering from one topic to another. They'll try to answer the question, and eventually they might come back to it, but they might just get completely distracted by their thoughts wandering off onto different topics. And this reflects their poor concentration and ease of distractibility. General appearance and behaviour, again, quite elevated moods will lead to an elevated appearance or presentation. So might be wearing brightly coloured clothes, they might be wearing revealing clothes if they're sexually disinhibited. Poor ADLs, their presentation might reflect their impulsivity or their increased activity. Rapid, constant movements and activity can be quite disorganised as well. Again, because of that distractibility and poor concentration, they can be find it difficult to follow through with one task that you set. So their behaviour can appear quite disorganised, and that can also lead to the poor hygiene and poor ADLs. They can be quite sexually disinhibited in their behaviours. So, and again, this could be due to increased libido, or it might be due to their impulsivity. Their behaviours can be quite disinhibited. Orientation, similar to last week, it's not necessarily that there's a cognitive problem that's affecting their orientation. They're going to know where they are and who they are, but again, their activity will be so quick and so distracted with such poor concentration that they can easily lose track of time and lose track of what day it is. Thought form, this is where you might see formal thought disorder, which is where somebody's thoughts are obviously not following a normal sequential logical process. They can be jumping from topic to topic, they can not be making any sense at all in their conversation, and again they can be describing their thoughts as racing. Thought content, this is where we come to this idea of delusions of grandeur or grandiose delusions, same thing, different phrasing. And that's usually where somebody has a fixed belief that's untrue, but they don't realise that it's untrue. And a grandiose delusion is one that their idea is of a self-inflated importance of themselves usually. So it might be that they are the best in the world at some particular activity, or that they're the best looking, or that they're God, or that they're a particular they are the Prime Minister, they're in charge of everything. It can also be religious, paranoid or persecutory, but usually in bipolar or in mania, you'll see delusions of grandeur. Now obviously with all of those symptoms that I've just described, a person's judgment can be significantly impaired. Because of grandiose delusions, their risk-taking behaviours might occur more frequently. They'll usually be things that the person wouldn't usually do. So they're making poor decisions in relation to sex. Disinhibition can lead to sexual behaviours or drug and alcohol use they wouldn't usually engage in. Overspending can be a big problem for people that are manic. Racking up credit card bills, buying new cars, buying houses, often under the belief that they've got lots of money, or that money doesn't matter, that they're allowed to take things. Insight, when someone's acutely manic, they're unlikely to have much insight into their behaviours or into the consequences of their behaviours, or into the need for treatment, particularly if somebody is experiencing grandiose delusions. If someone thinks that they are the most important person in the world, or that they are somebody of some particular importance, it can be very difficult to try to explain to them otherwise that actually you're unwell. There isn't anything particularly amazing about you. You're a normal person going about your normal life, but you're manic at the moment and you're experiencing grandiose delusions. If you try to tell somebody that when they're manic, they're not going to believe you. So usually it is best to try to get in just before when somebody's on their way up, looking for early warning signs, seeing that someone's starting to become elevated, starting to become manic, so that they can get early treatment to be able to shorten the time of their mania. Memory is unlikely to be impaired unless they're under the effect of drugs or alcohol. Most people will say that they don't remember their behaviours during a manic episode, and that could be for a number of reasons. It might be that there was just so much going on at the time that they can't remember what was happening, or it might be that they were experiencing traumatic events during the time. It might also be that they just don't believe what it is that they've done. So someone who, if we think back about Ella in the simulation activity, Ella, when she is well, she is very religious, doesn't engage in kind of risk-taking behaviours, but when she is unwell, when she's manic, she was told that she was displaying a number of behaviours and symptoms that actually she wasn't comfortable with. Intelligence. Now, under intelligence, you might include things like concentration and distractibility. So poor concentration could fit under this section as well. Intelligence can include other cognitive issues rather than just IQ. So you could put poor concentration and distractibility here. And biological issues. As with depression, as bipolar is another mood disorder, there are a number of aspects that you would put under here that you need to assess quite closely. So sleep. Now these things can change either as early warning signs or once someone's completely unwell. So someone might start to report a decreased need to sleep as an early warning sign, and it's usually a pretty good indicator that a manic episode's on its way. But also a lack of sleep and increased physical activity can trigger a manic episode. So someone who has bipolar is advised strongly against working night shifts or working shift work, because having that disrupted sleep pattern can trigger a manic episode. And lack of sleep is a major contributor to physical exhaustion, which is one of the major risks of mania. Appetite. Someone could be too busy to eat. They might not consider their eating to be important. They could be too distracted, too physically restless to sit and eat a meal. When they do eat, they're not going to really care about whether they're eating with a knife and fork and wiping their face. Sleep and appetite are the two main concerns in mania. Someone can be so physically exhausted and not eating enough that they're at risk of nutritional deficit, food and fluid intake's really poor, risk of dehydration, and often that's one of the main reasons why people end up being given compulsory treatment, because they're actually kind of fading away from all of their activity and lack of sleep and eating. We'll talk about some nursing interventions for managing those presentations shortly. Medical disorders, again, as always, come under the biological section of the MSc. You need to consider if there are any other medical issues, and I've already said you need to rule out drug use. So nursing diagnoses, or as always, very specific to the individual client's presentation. People present with a range of different symptoms, but some of the common ones might be risk issues related to their behaviours that are associated with their poor judgment. So if the person is presenting with disinhibited sexual behaviours, then there might be risks of STDs, unsafe sex. If someone's presenting as being with poor judgment but they're overspending, then obviously there's risk relating to financial issues and debts. And that can be a really, really big problem for people where whilst they're manic, they're spending a lot of money that they don't have. Once they get treated and they come back down again, they realise exactly what they've done. It might be that relationships are ruined, marriages are ruined because of sexual behaviours that occurred when the person was unwell, or there might be significant financial stress arising from the spending that occurred whilst they were unwell. As I've already mentioned, physical health issues, so at risk of physical exhaustion related to poor sleep, nutritional deficits related to food and fluid deficits, and treatment issues. We always need to consider how likely is someone going to be to engage in treatment if they're already manic, and they'll be less likely to engage the more manic they are. Non-compliance with medication, always an issue as well. So the nursing interventions obviously need to be quite specific to that presentation. We need to make sure that we're maintaining safety, assessing the person's need for compulsory treatment, maintaining a safe environment, and ways that we might do that might be that we're looking at does the person need to be specialed? Does the person need one-to-one constant observations by a nurse of the same gender? If someone is manic and sexually disinhibited, you might want to, if it's a female, you might want a female nurse, and you might want to make sure that they're staying in open areas of the unit if they're in a ward situation, to avoid any kinds of sexual behaviours with other patients on the unit. So it might be nursing them in the HD area and high dependency area. It might be one-to-one. It might be, I've also nursed clients who have been so sexually disinhibited that they'll keep taking their clothes off, that they'll be urinating in the courtyard, that kind of thing. So we always need to be trying to maintain the person's privacy and dignity as best we can. Interventions to assist with compliance or engagement of treatment. Obviously there may end up being use of compulsory treatment. If someone's a voluntary client, then we need to have the ongoing assessment of whether or not they're able to remain a voluntary client. Providing as much psychoeducation as we can around the illness and around medications. Providing psychoeducation to the family. Involving the family and carers are obviously very important, because they're going to be involved throughout the whole episode, and they're also going to be the person taking care of the client when they return home. So making sure that they're aware of what behaviours are related to their symptoms. And anything we can do to maintain their good physical health. So I've just mentioned that exhaustion and food and fluid intake are massive issues for people that are manic. So we need to consider how we're going to address that. If someone's manic and they're not sitting down to eat a meal, then we might be looking at giving them highly nutritious small snacks. So it might be muesli bars, things that they can keep in their hand and keep eating at even when they're walking constantly and not sitting down. We don't want to be trying to force somebody to sit down and eat a 3-course meal. It's not going to work. All it's going to do is ruin your relationship with that client. So you do need to be trying to think outside the box a bit. You might get the person a resource drink, one of those extra calorie drinks. Again, the person can drink it whilst walking around. Constantly encouraging water. It might be also about things that you do need to restrict while somebody's manic. Should we be giving someone full caffeine coffee if they're manic and not getting enough sleep? Should we be giving them Coke? So there's lots of things that we need to consider in terms of improving physical health. Now, once someone starts coming down from being manic, there's also can be an increased risk of suicide. A lot of people who I've spoken with about their mania, when they're well, they say that they actually hate being well, because when they're high, it feels amazing. They feel powerful, they feel like there's no stress, everything's amazing. So obviously if someone can be in that state and then they have to come back down to reality, that could be quite upsetting for somebody. And again, as I've noted before, the issues around the behaviours that occurred whilst they were manic, all of these things can be risk factors for suicide when the person becomes well. So let's have a look at treatments. We are going to introduce, as I said last week, we're going to introduce the idea of ECT. I would like you all to have a look at this YouTube clip. It is done by a British healthcare agency, and it will give you an example of ECT being performed. You may see it whilst you're on placement. I know that at least 4 of the placement services do ECT, and you will get a chance to do a rotation through. We're not expecting you to have a complete understanding of all the ins and outs of ECT, but I would like you to have an awareness of it. It is a preferred treatment for some people, and it's used in depression and used in bipolar. It also is occasionally used in schizophrenia. It's often used as a last resort. The reason for this is that people still don't like it. It has a lot of negative stigma attached to it. It really gets a bad rap because it's actually quite an effective treatment and is less intrusive than having to take medications every day. A lot of the medications we talk about have some serious and severe side effects, things like increasing risk of obesity and then all the health risks associated with obesity. Whereas with ECT, it's not particularly intrusive. It's usually done 3 times a week. for 3 to 6 weeks, and that will be the whole course of treatment. For some people, they might have maintenance ECT, but they might go back once a week for a prolonged period of time, or they might go back once every 2 weeks. It depends on the person's treatment. It's used a lot where people are sensitive to drugs, or where they can't take medications for particular reasons. So elderly, it's used quite frequently in the elderly because there are often a lot of issues with polypharmacy. Or somebody might not prefer to take medication, so they actually don't want to be taking tablets 3 times a day. They'd rather go into the clinic for half an hour, have their ECT and get on with their day and not have to take medication. It is done as an outpatient therapy. You don't need to be admitted to hospital. It can be done as an outpatient, or if you are already in the mental health unit, then you can be taken to the outpatients area of that same hospital for ECT. It's also done when there's an urgent response required, so it can have fairly quick turnaround time for improvement. So even though it's done over a 3 to 6 week period, you can usually start to see improvements quite quickly, sometimes even within a week, particularly where there are high risk presentations. So somebody who is quite hyperactive in their behaviour, or presenting as quite a risk to themselves or others, ECT can be quite useful for a very quick response. And you'll read some more about the other psychotherapies. As with most of the mental illnesses we cover, CBT can be used, and this concept of interpersonal use of self. So that's really talking about all of this rapport building, the therapeutic relationship. Your relationship with your client is a treatment in itself, and it's often going to be the most important treatment, because that's how you keep somebody engaged in their healthcare. So you can also use the therapeutic relationship as an intervention, as a nursing intervention, or as a treatment in itself. Group therapies can be quite useful, particularly for psychoeducation or for carers groups, to provide education and support. Pharmacological treatments, we've got 2 groups. Again, we're using benzodiazepines here and mood stabilizers. There are a number of different mood stabilizers being used currently, but 2 of the most common ones are lithium and sodium valproate. Benzodiazepines are used either as PRN, or they might be charted short term for people who are in an inpatient environment where there's a significant behavioural component to their presentation, where there's physical agitation, aggression, restlessness, again to assist with things like sleep. Because sleep is such a big issue, and the risk of exhaustion is an issue for a manic person, then we might be using benzodiazepines to help try to bring the person down. They are only short-term use. They might be given up to 3 times a day to assist in management of behaviours, or to promote sleep and reducing the activity, but they would only be used over maybe a 2-week period for an inpatient setting. You won't see somebody who is well taking benzodiazepines for bipolar. You will see people staying on mood stabilizers. So once you've been diagnosed with bipolar, you will usually need to be on medication for life. However, that can obviously be reviewed as required. Mood stabilizers are the major group that are used for treatment for bipolar, and they do exactly as it says. It's there to stabilize a mood. They're not used as PRN. They have no effect PRN. They need to be taken so that they're taken consistently and built up to the right levels in someone's blood before they will be effective. They usually take maybe 2 weeks or so to start seeing an effect, but it's very different in each person. You'll see more information about pharmacological treatments in the additional resources sheet. We'll need to go through all of the side effects, the doses, the nursing interventions to manage the side effects. So we've got an example MSE for bipolar, so you can have a look here to prepare yourselves about how to interview someone who is manic. Again, very good preparation for the simulation activity this week, as we will get a chance to interview someone who is manic. Clients' experience of bipolar, as I've said last week, one of the focuses in this course is being able to understand the experience from the client's perspective and from their family's perspective. This is a very important component of the recovery model, being able to understand how these symptoms affect real people in real life. It isn't just enough to know, okay, these are the symptoms. You need to be able to understand how they can affect people, because they can affect people very differently, as well as their family. So if you do have time to watch this clip, pay particular attention to people's stories about how they engaged in treatment, what worked to get them to engage in treatment, why some people don't want to engage in treatment, and look at medication compliance issues. These are the kinds of issues that you'll come across in clinical and that are problems with maintaining compliance. So it's good to get an understanding of it from the client's perspective. So I'll leave it there. Remember that there's another test in the tutorial next week or this week on bipolar, and it will be the same process as what we went through last week. So if you can't attend, make sure that you send me a special consideration application, which you find online, and I'll arrange a time for you to come and do the test in my office. Be sure to look at the learning outcomes for this week. You will need to have a look at some material from your textbooks, and of course the documents that I've referred you to in this lecture in the additional resources section. If you have any questions, feel free to email me.